Hey podcast listeners, Jim Sigler here for BrainWaves. In acute stroke, as you know, certain clinical symptoms are highly predictive of a large vessel occlusion. Neglect, aphasia, visual field cut, gaze preference. Signs which have enormous clinical utility because they indicate with a reliable specificity that there's going to be a proximal arterial occlusion. And nowadays, in the right scenario, that may identify a patient who's going to benefit from emergent endovascular thrombectomy. For the purposes of the show today, I want you to think of these symptoms as clinical biomarkers that possibly indicate cortical tissue injury. And this is why we traditionally think of them as cortical signs. But, like any biomarker, these cortical signs are not 100% sensitive or specific. You could have a right middle cerebral artery occlusion and no hemineglect. Or you could have a right-sided thalamic lacune and have profound visual inattention of that left visual field. So while these exam findings may be helpful clinical indicators, and they should certainly guide your clinical decision-making, it doesn't mean that they can't fool you. In this week's installment of the BrainWaves podcast, we're going to relocalize some of these cortical signs into the subcortical networks of the brain. I'm really excited about this program because I think it's a great program for anybody listening who's just starting out their second year of residency, just getting into neurology, or they're starting out on the wards for the first time as a medical student. We're going to cover a lot of really interesting content today that's going to be very useful when you're clinically evaluating these patients. And hopefully by the end of the show today, you'll be able to understand why aphasia or a gaze preference may be a subcortical syndrome. Stay with us. The thalamus is the bedroom of the central nervous system. At least that's what the Greeks thought of it. An inner chamber, or a sleeping room, buried deep within the cerebrum. As you know, its neurons serve as a relay station for a large number of signals and synapses between the spinal cord, the cerebellum, and various regions throughout the cerebral cortex. Anatomically, the thalamus is divided into three main components: a lateral region, which houses most of the nuclei, an anterior region, and a medial region, all separated by white matter fibers of the internal medullaris lamina. And from here, they are divided further into more specific nuclei, which we'll cover as we navigate through this episode. But why am I focusing on the thalamus here? Obviously, because of the topic of today's episode, it's because the thalamus plays a very critical role in modulating some of these cortical functions. So starting with attention, let's talk about how attention's processed and what the role the thalamus has here. Inattention, or neglect, is basically the failure to respond to one side of your visual or sensory world. This can be the result of impaired visual processing, poor somatosensory processing, or a loss of directed motor functioning, a sort of motor neglect where the contralateral arm doesn't really want to do anything, even though confrontational strength is fully preserved. And we see this often as a result of non-dominant inferior parietal lobule and temporoparietal occipital lobe lesions, cortical lesions of the right parietal lobe. But sometimes it can be tough to identify neglect when there's a component of a visual field cut. Only really with damage to the superior temporal gyrus do you see neglect in the absence of a homonymous hemianopsia. If you were to lose the temporoparietal occipital lobe from a stroke or a hemorrhage, then you can get hemispatial neglect and a field cut, but it can be difficult to differentiate between the field cut and the neglect a lot of the time. But neglect is not purely a feature of cortical injury, as no doubt you've seen in your own practice. It turns out that it's not uncommon in patients with isolated subcortical injuries, in particular among patients who have right-sided thalamic strokes. So now we're back to the thalamus. And I'll just go ahead and say here that there's no real clinical difference in the type of neglect that's experienced by a patient with a thalamic lesion than a patient who has neglect due to a lesion of the non-dominant superior temporal gyrus. More commonly, when there is thalamic injury as a cause of neglect, it involves the posterior half of the thalamus, a region that's supplied by the small PCA arterioles, the P1 thalamic and subthalamic perforators. The posterior half of the thalamus houses important structures like the ventral posterior medial and lateral nuclei, which receive somatosensory inputs from the contralateral face and body, and projects filtered sensory information to the primary sensory cortex of the parietal lobe. The lateral posterior nucleus is also affected in posterior thalamic lesions, and this region receives input from other parts of the thalamus, and it projects to parietal association cortex. And if each of these structures on the right side, or the non-dominant side, is affected, then the signals of the non-dominant parietal lobe can get mixed up. And in addition to diminished tactile sensation on the left, a patient can be left with a hemineglect in certain thalamic lesions. After reviewing the literature, for unclear reasons, more right-sided thalamic hemorrhages have been published in association with hemineglect than right-sided thalamic infarcts. But either forms of vascular injury can cause inattention. As many as 30 to 70% of patients with right-sided thalamic hemorrhage can have a left-sided neglect, but this may be driven by selection bias. Or it may be related to hemorrhage expanding beyond the boundaries of the thalamus, or creating local vasogenic edema, which may temporarily compromise additional subcortical fibers which signal between the cortical neurons, thereby impairing signals involved in maintaining attention. Hemineglect may also be a consequence of a disrupted intrinsic thalamic network, as some clinicians have postulated. Neurons of the thalamus serve more complex function than just a simple relay station for raw sensory or motor signals. In addition to some of its other more complex functions, the thalamic reticular nucleus, which is a GABAergic group of neurons, receives convergent inputs from multiple other thalamic sources, providing it with some raw sensory data. And here the thalamic reticular nucleus processes and maybe even filters some of this information for eventual distribution to other regions of cortex, which could potentially give rise to a visual or a tactile form of spatial processing. And the pulvinar nucleus is critically important in cases of thalamic hemineglect. As you know, the pulvinar is one of the largest thalamic nuclei, and its primary function is in directing and maintaining attention to the contralateral side of space. A theme of today's talk is going to be, how do we know the answer to these questions? How do we know that one region of brain is responsible for a specific function? And in general, there are two types of tests that we can do. In one way, we can assess whether a lesion causes a loss of a certain function. So whether a patient has a stroke or a tumor or damage to a certain area of brain, and there is subsequent loss of function, sometimes we'll just assume that that area of brain that's damaged was responsible for that function. But this is not exactly true. In a separate way, we can test the metabolic activity of certain brain tissues. And with increased activity of a certain brain region, we can assume that that brain region is then responsible for that function as the area is lighting up with blood flow mapping or bold signal changes. So when I say that the pulvinar nucleus is involved in attention processing, it's because we know that from either lesioning studies or from fMRI data. In addition to the other functions that I've described with the pulvinar nucleus, the pulvinar does receive visual sensory input from the superior colliculus, the pretectum, and extrastriate visual cortex, and it organizes this information into a map of your visual world. Information from this map is then relayed to the superior temporal gyrus, which we just mentioned is the singular region of cortical tissue that's damaged in hemineglect syndromes when there's no visual field defect. So the thalamus is more than just a doorway for information to pass through. It filters and, to some extent, does process information to a level that's not unlike what the parietal cortex does when that region mediates attention. Now, I've spent all the program so far highlighting the role of the thalamus in processing attention, and when it's damaged, it can result in neglect. But there are other subcortical regions that may be affected in hemineglect syndromes. Damage to the right-sided putamen, and to a lesser degree the right caudate, may also be related to subcortical causes of neglect. Moving on to aphasia next. Yeah, aphasia is classically a cortical sign, usually involving the dominant inferior frontal gyrus when there's impaired language production. Or if there's impaired language comprehension, then this involves the dominant superior temporal gyrus, which is the exact opposite side of the cortical region that's implicated in hemineglect. And this is the classic teaching from the Wernicke-Lichtheim model from the late 19th century. Extremely outdated, and it's now being supplanted by a dual stream model of language production and comprehension, where first a ventral stream courses through the temporal lobes and it's responsible for converting auditory information into meaning, and then there's a dorsal stream which spans much of the left frontal lobe and the temporoparietal junction that provides auditory feedback during spoken language production so as to make one's speech fluent.
Really? Yes. Okay.
So overall, language still remains a function of cortical processing, but with active involvement of subcortical networks that do distribute the responsibility of language comprehension and production in real time. But again, getting back to the thalamus, which is our sensory motor gateway, it also mediates language function to a lesser degree. And we know this from a lot of data on lesion studies. As many as 30 to 70% of dominant or left-sided thalamic strokes, or even hemorrhages, can result in some sort of aphasia. And this subcortical type of aphasia, like neglect, can be practically indistinguishable from the aphasia in a cortical lesion. One meta-analysis of published studies even reported that 44% of patients with vascular thalamic lesions had problems comprehending language, and 3/4 of patients had difficulty naming objects. The thalamic nuclei that seem to be the most critical to language function, or at least the ones most damaged when there's loss of those functions, include the ventral lateral and the ventral anterior nuclei, which get much of their input from basal ganglia structures that assist in planning and execution of skilled movements, like the articulation of language.
For the patients, I know it, you know it, and guess what? Dr. Cox knows it too, although damned if he doesn't disagree.
Other than the thalamus, lesions of the putamen and caudate bodies can produce a variety of disturbances in language expression. Mutism, and a lack of spontaneous speech, for example, is going to be seen in cases where there's damage to the left putamen. And the putamen is a major target for premotor, primary motor, and somatosensory cortical input, where the putamen may integrate these signals and respond with a more complex motor output to the ventrolateral thalamic nuclei. Next, in cases of damage to the insular cortex and parts of the adjacent subcortical white matter and posterior limb of the internal capsule, you might expect impairment in repetition based on what you know from the traditional Wernicke-Lichtheim model. And you'd be right, even with the newer dual stream model. These areas remain part of that ventral stream which converts auditory information into meaning and eventually tries to reconvert that meaning into auditory output involved in repetition. So there's more to language than just the cortical networks. There's still that dense subcortical network, and even damage to those areas can result in aphasia syndromes. But I think we've talked about aphasia enough, so we're going to move on to another classical cortical sign, which is gaze preference. And we see this with injury to one of the frontal eye fields. It's probably more accurate not to call it a gaze preference, but a conjugate gaze palsy. Still, most physicians will call it a gaze preference. And I'm only talking about the horizontal conjugate eye movements here when I'm talking about cortical signs. You see, because each frontal eye field, which lies just anterior to the supplementary motor cortex, directs saccadic eye movements to the contralateral visual space. So a sudden damage to one frontal eye field will drive your eyes to look in the direction of that frontal lobe injury. Eyes tend to look toward the side of the lesion. So in a frontal lobe stroke, you might get right face and arm weakness with a leftward gaze deviation. But those cortical neurons in the frontal eye field have far-reaching axon projections that span the entire vertical axis of the brain. First, they dive down into the corona radiata and the anterior limb of the internal capsule, so even subcortical injury in these areas may be enough to cause an ipsilateral gaze preference. From the anterior limb of the internal capsule, some fibers are going to synapse at the superior colliculus, while others will continue and decussate at the level of the midbrain and dive into the pons to a small region called the paramedian pontine reticular formation, PPRF. Each of the two sides of the PPRF directs gaze to the ipsilateral side of the pons. So while the left frontal eye field drives eyes to the right, the left PPRF is going to drive eyes to the left. How it does this is pretty straightforward, and pretty high yield for anybody taking board exams. Following the initial synapse at the PPRF from the frontal eye field axons, the ipsilateral abducens nucleus is triggered. Two signals then split off. The first one ascends via the medial longitudinal fasciculus to the contralateral medial rectus subnucleus of the third cranial nerve, which drives the contralateral eye to look nasally, and then the second goes to the ipsilateral abducens nucleus, which innervates the lateral rectus of that side's eye, yoking it along with the other eye to that ipsilateral side. Essentially, activation of the left PPRF is going to signal the ipsilateral sixth nerve nucleus to pull the left eye leftward and simultaneously signal the third nerve nucleus on the right side to bring the right eye leftward. It might be hard to imagine all these signals without some sort of diagram, but it's a pretty high yield pathway to know for your neurology boards and in your clinical practice. because damage to any one of these levels, from the anterior limb of the internal capsule to the PPRF, can cause a gaze preference that mimics a frontal eye field problem. To confuse you a little bit more, now that you know a right-sided capsular infarct can cause a gaze deviation to the right, there are even reported cases of right-sided thalamic and subcortical frontotemporal injuries causing gaze deviation to the left side. And some have called this WrongWay Eyes. More often, we see this in cases of intracerebral hemorrhage and not cerebral infarct, which has led to a ton of speculation as to why this happens. The truth is, though, nobody knows for sure. One theory for WrongWay Eyes is that the signaling for smooth pursuit breaks down. The visual association cortex in the parietal lobe, where smooth pursuit signals originate, sends its own axons towards the superior colliculus alongside the posterior limb of the internal capsule, immediately adjacent to the thalamus. So damage there can off-balance those smooth pursuit signals even from the same side, which may actually cause the eyes to look contralaterally. A second theory, which makes more sense to me and has some of the most data to support it, is that, particularly because hemorrhages create more mass effect than infarctions, thalamic hemorrhages and trapped intraventricular blood can compress adjacent structures like the midbrain, where the descending fibers of the anterior limb of the internal capsule have begun to cross before they reach the PPRF. The thought here is that this hemorrhagic mass effect displaces the midbrain tissue where the frontal eye field fibers have already crossed, thereby causing WrongWay Eyes, and also impairing alertness or consciousness. So just to recap, even acute subcortical lesions of the left side can cause patients' eyes to look to the same side of the lesion, which is going to be more common, or they could potentially cause the eyes to look to the opposite side, causing a WrongWay Eyes type syndrome, which can be really confusing. But you're going to get the imaging anyway, and you'll find out. To summarize what we've discussed here today, cortical signs of hemineglect and aphasia and gaze preference are going to be more distributed neurologic functions than you might have been traditionally taught. In particular, the superior temporal gyrus, which is a critical component involved in maintaining attention if it's on the non-dominant side, has broad connections with subcortical structures, including the pulvinar nucleus of the thalamus, the putamen, and to a lesser degree probably the caudate nucleus. Damage to any one of these structures, or to the subcortical white matter connections, can result in a disorder of hemi-inattention, which can manifest with failure to respond to visual or somatosensory input, or even failure to execute a physical or motor program in that side of space. For aphasia, sometimes we see damage to the putamen or the caudate nuclei. And then for gaze preference, we usually think of damage to the PPRF, but even midbrain and subcortical hemorrhages can cause a conjugate gaze palsy. More importantly, what I've said a few times now is that each of these cortical syndromes won't help you to distinguish a cortical lesion from a subcortical one. It's the clinical exam in total that may clue you into the localization. A patient who has fluctuating or impaired consciousness with a left gaze preference, that person's probably not going to have a left frontal lobe lesion, unless it's just a massive hemorrhage. You'll probably try to localize this to the right pons or the midbrain, or even to the left thalamus, where you can occasionally get that WrongWay Eyes syndrome in certain hemorrhages. A patient who has a dense expressive aphasia and right face, arm, and leg weakness, they shouldn't have a left MCA occlusion. It could be a left ICA occlusion, but it could also be a left thalamic or thalamocapsular lesion. You're going to get that head CT and probably some form of vascular imaging anyway, especially in these acute scenarios. But it's important to realize the usefulness and the limitations of these exam findings, because, again, they are just clinical biomarkers, and you should think about them that way. Like any diagnostic test, they're not always going to be 100% sensitive or specific. Well, I think we covered a lot today. There are other cortical signs we didn't get to, which can manifest after a subcortical injury, apraxia, homonymous hemianopsia, but we are short on time, so I hope you were able to take something away from this week's program. And if you like what you heard, let us know by rating the show on iTunes, Stitcher, Google Play, or wherever you get your podcasts. The BrainWaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. I'm Jim Sigler, the senior producer. Music for our show this week was courtesy of Austen Cedar, Nagno, Yishua, and Kevin MacLeod. For more information on what was covered, I'll refer you to the show notes, which do include the most pertinent references for each show's topic. If you like the show, you'll definitely enjoy some of our earlier shows on topics like the Cotard delusion, or delusion of self-death, episode 105, the 10,000-hour rule of expertise and skill building, episode 92, or episode 88, in which we discuss the movie Phenomenon as an example of a neurologic disorder which actually improves your body's functional abilities, and if there are any other neurologic conditions that can do this. So check those out. I'm Jim Sigler in Philadelphia. Thanks for listening.